Can you guys see my screen okay?
I cannot see your screen, Gail. If you're working on two screens, maybe try sharing the other one.
Okay, let's see here. There we go.
There we go. That looks great.
All right, sounds good. So today I'm going to talk about substance use disorder and mindfulness. The learning objectives today, I'm going to talk about mindfulness, grounding, and mindfulness-based relapse prevention. Despite the significant efforts by individuals, communities, and providers, relapse rates remain incredibly high, with data suggesting that more than 2/3 of individuals return to substance use within 1 year of treatment. The relapsing nature of substance use disorder has made it clear that relapse prevention education is essential. The most common intervention, identifying a high-risk situation that can increase the probability of relapse and the development of specific strategies that individuals can resort to when they are exposed to them. The definition of mindfulness is a moment-by-moment awareness of thoughts, feelings, bodily sensations, and surrounding environment. Being mindful is related to being open, non-judgmental, friendly, curious, accepting, compassionate, and kind. Practicing mindfulness has been shown to help regulate attention, cultivate acceptance, and develop the ability to observe inner experiences such as thoughts, feelings, and physical sensations without judgment. Grounding, on the other hand, is a technique for regulating overwhelming and difficult emotions, a sense of safety in the body. Grounding techniques are needed when we are outside of our area of comfort. In the context of addiction treatment, mindfulness can promote awareness of external and internal triggers for addictive behaviors and improve tolerance to uncomfortable emotional, cognitive, and physical experiences. It can also have a significant effect on decreasing cravings after treatment. Mindfulness doesn't just foster a pleasant moment of calm. The literature discusses mindfulness as a powerful tool for altering and strengthening key brain networks, promoting positive change in brain pathways involved in stress, focus, attention, memory, and mood. Mindfulness over time can physically change brain structures long-term, including age-related brain degeneration. Here are a few examples of mindful-based interventions. The first one is being present. Being mindful starts with paying attention to ordinary things, the sensation of your feet rising and falling as you walk, the feel of soapy water sliding over your hands as you wash dishes, and the taste of texture of food in your mouths as you eat a meal. Doing this regularly may take practice, but it's one of the easiest mindfulness exercises. Noticing the little things will ground you in the present moment, the place where you live your life. The next one is breath or breathing. When people are stressed, it's easy to get sucked into damaging spiral of self-defeating thoughts. They need to actively take care of their emotional health in these moments. Focusing on their breath can restore a sense of calm and control that keeps the recovery on track. They should be encouraged to take small, mindful breathing breaks throughout the day while they're at a stoplight or waiting in line, or before they decide to open their emails or go to a meeting. Inhaling through their nostrils and exhaling through their mouth, making exhalation a little bit longer than inhalation. They should notice the sensation of air entering and exiting their body again and again, always there to calm and sustain them. The next one is recognizing thoughts are just thoughts. Negative self-talk is a common activity and it's destructive in recovery. Recognizing and challenging these thoughts allows them to be more hopeful and lighter. Encourage them to check in with their thoughts throughout the day, especially when they find themselves becoming anxious or depressed. They can ask themselves which thoughts triggered their feelings. They can remind themselves that thoughts are just thoughts. They don't have to pay too much attention to them. Then just practice letting them go. Mindfulness teaches them to become aware of their thoughts, allowing them to let go of harmful ideas that work against them. The next one is expanding compassion. Addiction limits individuals' abilities to connect with others in any meaningful way. Compassion strengthens their ability to build health, healing relationships that positively affect their inner emotions. They can use the phrase, just like me, in the mindfulness meditations to promote compassion. They can repeat the phrase in their minds during interactions with others and remind themselves that everyone has hopes and fears, dreams and sorrows, just like me. The next one is being still. As a society, there is a tendency to equate busyness with goodness. The more activity individuals engage in, the better. There's a recognition that multitasking as a virtue and admire people who somehow manage to do it all. There's tremendous value in allowing people to step away from the busyness of the day and simply be. It is in stillness, not in continual activity, that people are free to discover their own personal truths that give meaning and purpose to their lives. There are some mindful-based therapies that assist in mindfulness, and here are a few. I want to briefly touch on mindful-based relapse. There's formal and informal mindful-based relapse. Formal mindful-based relapse is an 8-session group-based program. Each session is about 2 hours in duration. The session includes formal mindfulness practices as well as exercises and skills designed to bring these practices into daily life, specifically into situations in which an individual is high risk for relapse. Informal mindful-based relapse prevention includes the acronym SOBER and URGE surfing. The acronym SOBER stands for Stop, Observe, Breathe, Expand, and Respond. Stop, this is when they step out of the automatic mode or the autopilot. Observe, this is when they are coming into their body, considering sensations, discomfort, thoughts, and emotions, and they should greet whatever they find with an attitude of openness, curiosity, and compassion. The next one is breathe. They should take as many breaths they need and focus on the breath. Then expand. They become aware and notice if their body is tense or relaxed. Then they respond versus react, and be mindful with awareness of what needs to be done to take care of themselves, making sure their thought process is logical and in line with their values and ways of thinking. The other informal teaching is urge surfing. This is when they imagine something stressful, an urge, or a situation. The participant is to sit and write it out and stay with the distress. And over time, as the situation becomes more intense, the participant imagines riding a wave at its beginning, and as it grows, keeping balance and staying on top until it naturally begins to subside. Staying on top instead of wiping out. Here are some different physical grounding techniques. Probably my favorite, or the one that I use across all the ages, is the 5-4-3-2-1 method, where people identify five things they can hear, 4 things they can see, 3 things to touch, 2 things to smell, and 1 thing to taste. Here are some mental techniques that can be utilized as well, or some examples. Here are the soothing techniques that sometimes help people as well. Here are some different resources that would be helpful to you in your practice. And these are some that I've used in my practice as well. There's my resources. And that concludes my discussion about substance use disorder and mindfulness.
Thanks, Gail.
Let's see here.
Any questions for Gail? We can also take questions at the end. If there are any quick questions about mindfulness, we can open that up now, or you can save those for the end as well. I think Stephanie, you are next.
Yep. Yeah, I'll just keep it going from here. And then our goal is to just to have questions at the end. We'll have about 15 minutes is how we timed it. So let me go ahead and share this. All right, can everybody see that? See my screen?
It's good.
Okay, so we'll keep it going. Talked a little bit about mindfulness. Now I'm going to touch base on some cognitive behavioral interventions that we can use in substance use disorders. That's research-based, that can be very helpful for our patients. The primary ones that we see the most success with substance use disorders are cognitive behavioral, dialectical behavior therapies, assertive community treatment, our ACT programs, and then contingency management. I'm primarily going to be talking about cognitive behavioral therapy. This is the most research-based. It tends to be the most have quite a bit of success, especially in our sessions. If I don't think anybody can do prolonged 60-minute CBT or therapy sessions in general, but this is where we can add in 5 to 10 minutes of CBT type practices, to help with our patients to change their behaviors and potentially change the outcomes. I'll list the last 3 at the end just to kind of give you an idea what they are, if more information regarding those. So what is cognitive behavioral therapy? It is a structured, time-limited, evidence-based psychological intervention. It's used for a wide range of emotional and behavioral disorders. We have the most research and evidence supporting it for use in for most psychiatric illnesses, including substance use disorders. Psychiatric disorders are assumed to result from a faulty thought process, and that's kind of the basis behind cognitive behavioral therapy. Patients are assumed to develop these dysfunctional thoughts from a combination of their individual learning history and then general characteristics of human thought in general. And then the provider actively promotes this new learning process in the here and now. And so you'll have measurable outcomes kind of set with them that you'll be able to see the changes. So going into the little bit more. So is this on my screen? Okay. So how do we get to this thought process? The basis of it is we react without knowledge of our internal processes. And so we all do this. We just kind of react from previous experiences. Our core beliefs will generate this automatic thoughts. And then our initial reaction will be what we feel. And then our feeling will then kind of dictate what our next behavior is going to be. And if the behavior is ineffective, these ineffective behaviors will then strengthen our distortions and our core beliefs. So we get this, this feedback mechanism happening with our thought process and our behaviors and our feelings. And so CBT the purpose of it is to recognize these thoughts, feelings, be able to teach our patients how to then alter them so that then the behavior can be changed. And so what are core beliefs? Our core beliefs are kind of our ingrained beliefs that are set way back in childhood. They come from a combination of life interactions. It's essentially the way we make sense of the world, how we see it, and it's reinforced through our experiences. But it's different than spiritual beliefs. We may not explore our core beliefs. We may not understand them. May not know why we even have these core beliefs. And as I said, they will typically be set in childhood and last throughout your life. And so these core beliefs are essentially the background of what we assume and then what we do. It will drive our coping strategies. Then if a situation presents itself, it'll dictate what the automatic thought is, and then ultimately the reaction. And so when we think about CBT and how we could positively help patients change the reaction, is we come in at the automatic thoughts situation and help patients understand what that automatic thought process is, then what they feel, and then how they're reacting. And so the basis behind CBT is behavioral change. So the goal is not for the patient to develop insight into why they're doing this. We don't want to psychoanalyze them to make them go back to their original core beliefs and figure out if those are right or wrong, for lack of better terminology. But we don't want to change that. We don't want them to develop complete insight into going all the way back into childhood. We want them to be able to recognize in the now what they feel, and so that then they can just change that behavior. So the patient is considered an active partner in the therapy. The treatment goals have to be observable and the outcomes have to be measurable. And so that's something that, when the patient comes in and talking about substance use, if they're actively still using, if their goal is to reduce how much they're using, is it measurable and is it observable? So is the patient able to keep logs to show that their goals are being met? And I'll talk a little bit more about that on a different slide. But there is homework that has to be assigned as part of this process. And the homework is how patients can actually visualize in themselves that the change is happening and that they're meeting their goals or not meeting their goals, and something might need to change. And so with initiating goals, it's important to know what type of goals should be initiated. And so, as I mentioned, they have to be measurable and they have to be achievable. Measurable in the sense, as I mentioned previously, if a patient's goal is to reduce their substance use from the previous week, maybe they could say, I used 3 days out of the week, and my goal is to maybe only use 2 this week. So it's measurable. So when a patient comes back in, well, how many days did you, how many days was it this week? And they can tell you, guys can discuss it and set a new goal for the following week. And then the next thing to assess, is it achievable? If a patient says, my goal is I'm using every day, and next week I'm never going to use again. Well, that's simply not achievable. And so you have to help and meet the patient where they're at and kind of guide their more achievable expectations on this. And then you kind of have to assess it about approach goals versus avoidant goals. Approach goals, meaning, for going back to my previous example, this week I'm going to use this many days out of the week, which is less than last week, versus avoidant goals is I'm not going to use at all because I used once the following week. So which one will work better for your patient? And then internal goals or external goals. This is very important because it's helping your patient realize who gets to decide if they're successful. If it's an internal goal, then your patient gets to determine if they're successful. If it's an external goal, like, my goal is this week, my spouse not to be mad at me. Well, the success of that is determined by the spouse. And so for substance use, internal goals are generally the more common goals, but it really is dependent on the patient's situation. Here's just an example of something you can have the patient set up, and you wouldn't have them set goals in all of these areas, of course, especially if you have 5-10 minutes to add in little CBT snippets here and there. But maybe this week they choose regarding substance use, that'll be a goal. And maybe they'll choose the self-care. Maybe a goal is I want to go for a walk this week. And then they can, write down if they actually were able to do it, or any barriers. And so when you were able to have those few minutes to discuss their goals at the end of the session, then to decide new goals, then you can kind of see where they're at with it. A helpful strategy when you initiate any CBT, even if it's in little snippets here, when you're seeing your patients, is initially right away going through the advantages and the disadvantages of their substance use disorder. That's a really hard step for a lot of patients to do, but when they're able to do it with their provider, then they can actually verbally and they can verbalize it out loud, and then maybe you can help them even write it down so they can actually see what their advantages and disadvantages, and having that can help instill the change in being able to meet their goals. And then negative automatic thoughts is a central target in CBT. That's the thought process that hopefully they can start to recognize and change, and which will be self-monitored. And then when you come into the sessions and they kind of start bringing that up, that's when they can start, that's when you can help them come up with an alternative thought process. So then the resulting behavior can be changed. One of when you're undergoing CBT, even in these 10 to 15 minute sessions, you always want to have a Socratic dialogue. This is the most essential aspect of CBT. And a Socratic dialogue it's not judgmental. You're not giving the patient you're not giving them their outcomes. You're not giving them a solution. It's just an open discussion. You don't have any predefined outcome other than just like a respectful curiosity. You're just exploring their thoughts. You personally really don't even know where you're going when you ask the question. You're just wanting more information. With this type of dialogue, you get rapport. It reinforces collaboration, and it teaches the patient how to evaluate their own future thoughts more in depth. And so they will understand as they have these negative thought processes that come up, and then they'll be able to ask themselves these questions when they're in the moment, and then they can get themselves to a place that will change these negative automatic thoughts, and then the resulting behavior afterward. This Socratic dialogue essentially professes an ignorance of the topic with the patient. So the patient is seen as the expert in their own experiences, which is how it should be. Some examples is to instill a Socratic dialogue during these CBT sessions is asking for a clarification of the thought, any thought, a critical examination of the thought, asking more detailed oriented questions, but again, non-judgmental. You want to explore the source of the statement, have the patient even go back even prior to the initial thought, like what led to that thinking process, and then examine the implications and consequences of the statement. And then examine alternative views, and the patient gets to decide these. So you're just promoting the question. You're not giving them the views. If they're not able to come up with them, you still don't get to give them those options or those views. That's something that they then have to kind of think about. But you set the question and the foundation for them to be able to start thinking that in that direction. What is not the Socratic dialogue? Things that you would not do. So as I mentioned, it's non-judgmental. You don't disagree. So you can't disagree with their thoughts or discount any answer. This is their thought process. And we're not changing it for them. So you won't ever want to answer questions. There's no pre-identification of a specific replacement or alternative thought. You can't have random questions. It's focused on the thought and the situation and the behavior. So keep the questions centered around on that. You won't want to make suggestions or problem solve, as I mentioned. And again, the most important thing is lack of judgment. And here's just more tips on how the Socratic dialogue can be used. So again, use the series of questions. We won't interrupt, no right or wrong. You want to frame questions in the client's language on how they are speaking regarding that thought. Inquire about contradictions and inconsistencies. Let them be able to come to the understanding that it is a contradiction. You want to inquire about other possible interpretations and meanings, and then incorporate, of course, the client's pre-existing knowledge of it. So the whole purpose of this Socratic dialogue in CBT is you're teaching the patient how to evaluate their future thoughts more in depth. So when they are out of the office, out of these mini therapy sessions with you, they can do this on their own, and they will have the tools to be able to get there. So that was essentially the kind of behavioral therapy that can be used with substances. For the most important aspect is that dialogue. But I also want to touch base on some other really helpful cognitive therapies. If anyone is interested in looking into these as well, dialectical behavior therapy is awesome. It's a great therapy as well. And it uses concepts of mindfulness and acceptance of being aware of and attentive to the current situation and emotional state. And it has a lot of affirmation initially in it, a lot of helping patients to control intense emotions, and then the self-destructive behaviors. So there's really no contradictions sometimes in therapy, not in cognitive behavioral or dialectical behavior, but you want to affirm a lot of the patient's thoughts and feelings. And with that, they can develop trust, and then they can develop some acceptance and awareness of their own thoughts and then behaviors. Assertive community treatment, the ACT program, which everybody probably has knows it by. It's a form of community-based mental health care, and it emphasizes outreach to the community and individualized treatment approach. Great programs. The whole point of it is that it can be tailored to the individual, and a lot of these programs can do some amazing things for these patients. And then contingency management programs or behavior therapies, it's essentially using a reward system, and it can come from vouchers, rewards. Some programs and therapy groups can use like little small amounts of money on gift cards. Drug courts will have an incentive program like that, which is why it's so successful. And then it can for the desired behaviors, and that's essentially the reward. So those are some other options of behavioral therapy. And I wanted to throw this slide in, because this is something that's always important. You always want to make sure in substance use disorder, always just, reassess where your patient's at. Because that's always important in being able to be able to provide behavioral therapy in it for it to actually be successful. Always assess where the patient's at, and if they're not where you expected them to be, then bring back some of your expectations and meet them where they're at, and then the patient is more likely to be successful in their goals. And now I will go ahead and let Ed take it over, and he will discuss motivational interview. Yes.
There we go. I forgot to unmute myself. Thanks, Stephanie. Get my thing pulled up here. Yeah, so I got tasked with opportunity to talk about motivational interviewing. So I'll get this going here in just a second. All right. Can everybody hear me okay? Okay. So here's the learning outcomes. Just talking for a few minutes about motivational interviewing. My goal in just this short talk is just to have you maybe have a better understanding of what motivational interviewing is, and then just maybe a couple takeaway things to maybe implement in your practice if you want to. So we're going to go over the ORS model of motivational interviewing, and in the slide deck will be available. So Stephanie and I, we didn't coordinate this, but the start of mine was the end of hers. So the stages of change, right? Contemplation, preparation, action, maintenance. So again, we want to have that in the forefront of our mind as we're thinking about where the patient is at when we're trying to help them make a transition. And then readiness for change is kind of determined by these two, I would just say, main sort of categories. So how important is it for the patient? And then like how confident are they that they can make that change? So here's one of the tools that I'll sometimes use, or at least think through. It's called the change ruler. Again, you can ask questions like, on a scale of 1 to 10, how important is it for you to stop using this substance? And then on a confidence scale, how confident that you can actually reduce that substance use. So some follow-up questions that can sometimes be helpful as you're having these conversations with patients is like, hey, what makes you a 5 instead of a 3 or 4? Or what would it take for you to get from, a 5 to a 7? So if somebody has a low importance, sometimes it can be helpful to use like a hypothetical question. So, what would have to happen for you to be ready to change can sometimes be helpful. What would it be like if you made this change? And then if you don't change, what may happen? So again, if I'm asking someone about their methamphetamine use and they're like, I like using methamphetamine, or it's helping me get through my day or whatever, it doesn't seem like it's of high importance to them at this point. The goal is just like, hey, we're just trying to plant a seed in their mind. What would it, what could it be like if I didn't use it? This is probably more where my brain goes when I think about having this conversation. It's sort of just like the pros and cons list, right? So I think through this when I make a lot of decisions in my life, but the pros and cons is like, what are the benefits of not changing? What are the costs of changing? So again, benefits of not changing, it might be easy. You don't have to, do a lot of hard work. Cost of changing is going to take time. It's going to be inconvenient. You're probably going to have some withdrawals if we're using the methamphetamine or any really substance use. And then the other side of it is like, what are the costs of not changing? So again, there may be legal problems, financial issues, and then generally want to end with like, hey, what would the benefits of changing be? So try to think about, what is a positive thing that we can end with this sort of pros con list. So again, you're not going to use like all the tools, but there's just some different ways that you can maybe have that conversation with people. If somebody has a low confidence, like, maybe they want to change, but they're not confident they can. So we just want to try to do like, hey, what has worked for you in the past? We're trying to do some brainstorming. Maybe one of the questions is, what do you think would work for other people who have been in this situation? Maybe what's a good starting point, or what ideas do you have? So again, just thinking through, like, when you ask them the ruler things, if they're low on confidence, or if they're low, just going back to importance, there's a couple ways that you can sort of follow up on that. I always like to think through like information versus motivation, right? And so I think that we tend to at times give people information, and I often think that people changing is not necessarily an information issue. It's more of a motivation or intrinsic issue. And so the example that we talk about in this is like sort of smoking, right? Like, most people can read the warning on the smoking, on the cigarettes. Like, we spent a lot of money to try to educate people, but just telling people that, smoking is bad for you, that you could get cancer, it could be costly, that information does not necessarily actually change people. And so we want to get to more of a motivational side of like the intrinsic value. So let me talk just a couple of minutes about sort of motivational interviewing and what it is, and sort of how it can be helpful for our patients. So again, it's just one of the tools to promote behavior change. When I think about motivational interviewing, I think like, oh, this is going to take me a really long time. And so trying to remember that, like, hey, what are a couple things I can do to make this brief in my, 5 to 10 or 15-minute interactions with my patients? It evolved from this alcohol abuse with William Miller. It's patient-centered. Again, we're trying to elicit this intrinsic motivation to affect change. And the provider is really trying to be a guide in that. And so I'm going to actually share just like a 2-minute video here. It just sort of talks about motivational interviewing from one of the, I would just say maybe one of the experts. So I'm going to roll this out here.
Fundamentally, motivational interviewing involves a change in role, a change in how you think about what you're doing. You're not the expert there to fix the person. You don't have to make the person change. The truth is, in fact, that you can't make a person change. You don't have to be the one to come up with all the good ideas. A person with really good ideas is sitting across from you and may have better ideas than you do. It's not like a competitive sport. It's not like wrestling where you try to defeat and pin and outsmart and outwit the person. It's more like dancing together, moving together, adjusting your movements to the other person. Overall, motivational interviewing is not a directive approach. Neither is it just a following approach. Following is listening to the person and kind of going wherever they go. Motivational interviewing is in the middle between those two. And we describe it as guiding. If you go to another country and you hire a guide, you don't expect the guide just to follow you around. That's not what you're looking for. Neither do you expect the guide to order you when you will arrive, when you will leave, what you want to see, what you will enjoy, what you're going to do. That's not a good guide either. Good guiding involves good listening, as well as using your own expertise. A good guide will find out where you want to go, what you're interested in, what you're hoping for on this journey, and then help you get there using his or her own expertise, enjoyably, safely, efficiently, perhaps. That's the guide's job. Not solely directing, not solely following. There's some of each in it, but it's a blend of those things. This may or may not be the way you've been thinking about your own work, but we invite you to try it out.
Okay, so again, just trying to like simple takeaways, like as I'm thinking through having a conversation with someone, I'm really just trying to guide them and be a part of the solution and not have to come up everything myself. Here's a study for you that just says, brief motivational interviewing may help patients achieve abstinence. They were studying heroin and cocaine in this. And it can be most effective for stopping preventable unhealthy behaviors like binge drinking, smoking, substance abuse as well. All right, I'm going to spend the last couple of minutes here just talking about another sort of model. This is the OARS model of motivational interviewing. So again, the acronym is open-ended questions. Try to avoid the yes/no questions. The second part of it is trying to lean into affirmations that support and encourage the patient. Reflections and summaries are sort of similar. So reflections are sort of like when a patient says something, you sort of reflect back to them what they told you. And then the summary is like sort of what we're doing at the end of this active listening of like, okay, so here's what we've been talking about. This is what I think is going on. Here's the next steps. Does that sound like what's going on? And is that what we're planning on doing, or are those what the goals are for the next time? So again, these are not new things for anybody, right? We don't want to use closed-ended questions. We want to use open-ended questions. I'm not going to read through all of these, but there's just some lists of examples of maybe different ways to ask those questions. And then here's like 5 sort of easy questions for you if you're thinking about motivational interviewing, or if you get stuck in a conversation with somebody and you're not really sure what's the next thing I need to ask them. Like, these are some that you can just go back to. Why do you want to make change? How might you go about making this change? What are the best reasons for you to do it? How important is it for you to make the change, and why? And then what do you think you'll do? So again, this is just sort of like a blanket, like, oh, here's some super easy questions to ask somebody when you're trying to kind of dive into some maybe motivational interviewing. Again, the second part of motivational interviewing is affirmation. Really important to affirm the behavior as well as the character. So, hey, you actually went to the meeting. That's really great. Sounds like you're really insightful about the triggers that cause you to drink. So, talking about both behavior and the character. Again, another affirmation example. Again, these slides will be available. The reflections, again, it's sort of just like this idea that even what Stephanie was talking about, just like active listening, right? You understand what the patient's saying, demonstrates you're on the same page, and it sort of helps encourage additional conversation. And so again, it's sort of like restating what the patient is telling you and asking if that is accurate. Reflections can be made in situations, again, of ambivalence, or if patients need a reason to change. Like, I'll read this last one. I want to be there for my family, but meth keeps pulling me back. Sort of the reflection is like, it seems like your family is a powerful motivator for you, but meth is also a strong force in your life. Is that sort of accurate? And then the summarizing, again, sort of like a longer form of reflection. you know, the final questions are sort of like, where does that leave you? What do you think you want to do? And what's next for you? And so just sort of like, again, along the lines of like setting reasonable goals and seeing what we're going to do in our next interaction. This is just a repeat of that slide about the questions. Okay, so I have one final thought for you, and then we'll go to sort of more broad questions. But this was a new concept for me, this idea of change talk. And so until somebody like taught me about change talk, I didn't really know it was happening. But we think about like change talk versus this idea of sustained talk. So a change talk sort of sounds like a person's own statements that is in favor of change. So if you hear language that's like, I desire to change, or I can change, or this is the reason I want to change, or I need to change, those are all good signs of like change talk. Sometimes you'll get into conversations where patients do what we call like a sustained talk. And what this sustained talk sounds like is this sort of like never ending list of reasons why I can't change and it's not my fault. And every other circumstance around it is preventing me. And so when I didn't know that like that there was a difference between these two. And so when I was a lot of times seeing patients, I would get it with patients that are doing this sustained talk. And I wasn't recognizing it first. So if you recognize someone's in more of a sustained talk versus a change talk, then we can try to like direct that conversation back to a change talk. And so again, when we recognize that, we want to switch people into like thinking about or maybe moving it to what change talk would sound like. So again, patients that are doing more of a change talk will say things like, I hope, or I wish, or it's important to me, I have to, I'm going to, versus just more of a slew of reasons of why I can't. And so again, that was just a really helpful piece for me as I'm interacting with someone of like, hey, what kind of talk are we having right now? Is it change talk or is it just more of a sustained talk? So again, the slides will be available for you all, but that's sort of the end of the motivational. I do just have one final thought as I stop sharing my screen. When I'm entering into those conversations with patients, one thing that I really like to think about, and obviously when I'm like training other providers as well, is like having conversations about substance use, is this idea of just like a curiosity. And so sometimes I'm looking at someone's drug screen and they obviously are positive for substances, or they've been gone for a long time. And I may assume like this patient is always missing appointments, but like trying to go into the conversation with curiosity can really open up a helpful dialogue with them, because sometimes I'm assuming something on my own end, but if I go within curiosity, it's like, oh, actually this patient, you know, recently had someone who passed away, or they actually were incarcerated and that's why they didn't come in, or some other life circumstance around the substance use. So just leaving you with like, hey, when we go into the conversations with them, really trying to be curious can be really helpful. All right, well, I'll hand it back to you for question discussion time.
Thanks, Ed. Yeah, we've had a few folks asking for the slides, and I've got all 3 slide decks now, so I'm going to send those out with my usual follow-up email this morning. We did have one question from Jet about mindfulness. Maybe Gail will have you, if you could help us answer this, or anyone. 2 questions actually. How can one find out about how and where clients can access formal mindfulness training? And then the other question is any recommendations for particular courses for providers? Janet did put in a link for providers. Yeah,
I just looked that up, and that PESI is a nonprofit that has a bunch of resources for you to take it yourself or to be a provider and teach it. So they had a lot of options anyway.
There's also on the resource slide that I have in my slide deck, there is a website for clinicians. I'm not for sure if I put that one on the slide, but there's like audio to help people kind of guide them through some of the mindfulness training and things like that. But I will add that website over here to the chat too.
and then in terms of finding formal training for patients, any thoughts? Anyone have any thoughts on that?
Well, I think the same group has resources for patients as well. I mean, there are a lot of resources out there. I don't know, there are a lot of apps that can be downloaded for free. I mean, I think there are many options, and fortunately kind of different ways they're presented for different patients, but I think a lot of that's readily available just by kind of Googling it.
Mhm. Absolutely.
Let's see. We have a question from Kevin here. From a previous ECHO presentation. This is kind of changing topics here real quickly. It says, doesn't it seem reasonable to use our knowledge regarding the safety and efficacy of buprenorphine as both an effective treatment for addiction and as an effective analgesic to select buprenorphine as the first line opioid when opioid pain medication is being considered in order to prevent iatrogenic addiction?
I will answer that. Yes, yes, yes. A lot of it is just getting providers aware of it. You know, it's one of those things that it was hard to get providers to treat opiate use disorder with Suboxone for a number of reasons. A lot of it is just being aware of this, understanding how it works, understanding its benefits. I think, yes, I think we're starting to see a little tiny bit more of that, but it could sure be a whole lot better than it is. So you're absolutely right.
I may add one caveat about that. Remind yourself that as a partial agonist and a very long half-life, buprenorphine, the reason we don't think of it in acute pain situations, it is not as potent in acute pain physiology as it is in chronic pain physiology. So that's not a timeline, but that's a physiologic state. So, that's part of the bias I think we have against buprenorphine is when we try to use it for acute pain, it's not as potent. So people think it's not great long-term. So I think just being comfortable with switching early and often is another approach to take as well.
Right.
Yeah.
And sometimes for less severe things, a combination of, Tylenol along with, I mean, if it's not really bad, if of course the problem is people that are prone to addiction can get addicted very early. And I think that's the issue to watch out for.
Hey, John, can I ask you, since I don't work in the pain world, so I always work in the substance use side of things, but give me an idea of what was a dose you would start someone on for some sort of normal pain on a buprenorphine short term versus oxycodone or something.
Man, that's the question, and that's such an interesting one because what we are learning here is, for example, if somebody doesn't have use disorder physiology, and let's say they're just taking 3 hydrocodone a day, they're gonna be responding to maybe 5 micrograms an hour of buprenorphine or 150 micrograms a day. In other words, it's a 100 to 1. But then somebody who maybe has been using the opioids for a short period of time, but has all of the kind of genotype and worries about addiction, in their background, they're going to have they're going to be more less sensitive to that. So they'll use up to 10 times the amount. That's the one trick, is that, every other opioid, we kind of know what the conversion is, oxycodone to morphine is 1.5 to 1 and what have you, but there's about a 10-fold change between the relative potency of legacy opioids and buprenorphine based on whether somebody has that addiction physiology or not.
Right.
So a little old lady who's taken 3 hydrocodone a day because she's got a hip that we can't fix because she's too sick is going to respond to 5 micrograms an hour of buprenorphine perfectly. But if she's been a lifelong drinker and smoker and has she may need a milligram of buprenorphine once a day. And it's very hard. So it's in our world, we kind of figure out how much of that dopamine physiology they have going on based upon what they prefer. But you just slide along with them like a sliding
Yeah.
scale. That's a
It
great
is
question.
really hard. I agree, John. A thing that I don't know how to quantify or use, but I anecdotally noticed this so much in my practice is people that would look back to when they first started using opiates you know, they were maybe prescribed it for a bad knee or an appy or whatever. They said to me, I felt better than I ever did before. And it's not really a quantifiable thing, but it is a warning sign. And if there's some way we could find that out early in the course of a patient's use, I think we could possibly prevent, you know, switch to buprenorphine sooner. You know, some people hate taking an opiate because they feel crappy on them. Others feel fabulous. If you can sort those people out, you will have right there the people that are at risk.
The one thing you can say, and you touched on it twice, is this happens fast, right? And in less than a month for the wrong people. If somebody ever says, I take one medicine, I take one Percocet or even one Tramadol, and I feel energized, that's the person.
Mhm.
If they feel dopamine, they feel it. If they say I feel gross, then you have a time to wait. But as soon as you hear that, understand they're responding to the other part of the physiology.
Right.
And before it start to get the adverse effects of dopamine, decrease, you want to think about switching them. That's a really good point, Jen.
Yeah. And I think we need to train ourselves to ask,
Yeah.
you know, because it is diagnostic, honestly.
Right.
John, one final follow-up question on that. Do you do like multiple times a day dosing, or is it more of like a once a day dosing when you're describing that? Because oftentimes I'll tell my patients, they're on high doses like 8, 16, 24. Hey, we'll split this dose up 3 times a day for better pain control. Is that accurate or not?
Yeah, that's a little bit accurate, but to be honest, that might be more behavioral than physiologic, right? It still has a 35-hour half-life. And these patients are kind of acclimated to the idea that when I hurt, I take this and it lasts for 3.5 hours. So what I try to do is not force them to find the right dose right away, but I give them a little bit of leeway and I let them kind of think about dividing that dose into 2 or 3. And then I just warn them about kind of the fact that it's a slow acting agent. So you got to wait 3 or 4 days before you know. In the long run, then we kind of go into the normal thing where we say, all right, this medicine is great. Since this is your dose, let's use it once or twice a day. Yeah. We're not trying not to have to change their thinking too much, too abruptly to make it harder for them to do so.
Thanks, Kevin, for that question. It's led us a good discussion. Appreciate that. I see we're at the end of our hour here. So I put a link in the chat if anyone wants to do that survey now. I'm also going to be sending out an email with all the slides and a link to that survey again to get your certificate. And we just hope to see you all here back in 2 weeks. Stephanie's up 2 weeks from now doing a deep dive into drug screens. Look forward to that one. Hope to see you all then. Thank you.